Implementing Cpoe is a huge undertaking for any organization. The concepts and ideas we're going to discuss in this presentation are going to focus on Meditech, but they can be utilized for any EMR system that you may be using. We will look at some of the process and data standards, including software development requirements, interface requirements, conversion requirements, training requirements, and finally testing requirements. In regards to software development, Meditech has already developed the software, but as you know, you can customize the dictionaries and some of the processes to fit the needs of your organization. We're going to focus on some of the specific dictionaries that you need to look at when you're implementing Cpoe. It's best practice if you already have a committee set up that has developed a style guide to help your builders know exactly the format and the wording and abbreviations that your organization is going to use throughout the whole process for every dictionary and every department. You need to make sure that you include departments like lab and radiology so that you can help it so when they get the order on their end, they know exactly what you ordered, but you're also meeting the regulatory requirements that they need on their end to make sure that everything is legal. You're going to need to review the order sources and potentially make changes to how they're set up or even add some order sources. As you know, you have to now know whether it's a Cpoe or non-Cpoe order, and depending on the order source that's defined, that can have a negative effect on your meaningful use numbers. So you definitely want to take a look at what these order sources are, how and where they're being used. As you know, a written order doesn't get prompted for electronic signature because it's already signed on paper. We have facilities that have telephone and verbal orders that are out there that do get prompted for electronic signature. We've seen facilities remove those options because they don't want people selecting that. But you have to have another process in place so that if the doctor's not there to place the order, how's the nurse going to be able to proceed with her day? We've also had some facilities that have just combined it and put telephone/verbal order. You also need a way, if your hospital has a protocol that allows a nurse or somebody to do something without a doctor being present, legally you have it documented on paper, it's fine, but you want an order source of that just so that it could be tracked for auditing purposes later on, and make sure that it does get prompted for electronic signature so the doctor knows that it was performed and he can sign off on it. Also, people are setting up plans of care or care plans as an order source. And finally, we've seen facilities that want to track just only what the doctors are ordering, nobody else. So they set up an EPOM or something that is specific to the doctors. They don't allow the pharmacists or anybody else but the doctors to use that order source. Earlier we talked about your committee that created a style guide. Here's where the style guide is going to really come into effect. You need to review every dictionary or every procedure that is built in the OE procedure dictionary, whether it be for the nursing department, lab, radiology, dietary. You need to look at the naming conventions and figure out, are we going to use tall man lettering? What's the industry standard abbreviation or acronym? Are we going to use that? Most lawyers are going to say you need to use the legal name for that order. But as you know, when you're building in Meditech, you're limited to the fields that are available, so you have to shorten some of the descriptions. And you want to make sure that it's standardized all over the board so it's easier for your doctors and nurses to find that order. An example is a computerized axial tomography scan of the head is the legal name. That's not going to fit in the Meditech description. So you could shorten it to either CAT scan or CT. Most places are going to choose CT, but again, your facility needs to know that because whoever's making the dictionary edits has to look for every time that the word CAT scan is in the dictionary and change it to CT. You also need to look at some items such as your contrast. Down below you see, it's shortened with a W. We've seen it where people spell it out. Some people do W/, some people do it uppercase, some people do it lowercase. You just need to standardize that and have it so that it's easy for the users because it's standardized for every procedure no matter what department that they're using it in. Order strings are another thing that needs to be evaluated by your committee and addressed in your style guide. You need to review the format of those and figure out whether you're going to spell out or use abbreviations on your frequency schedules. You also need to look at common order strings and whether a drug is going to have more than one, and how are you going to lay that out, and what's the order that things are going to be laid out in the order string. The medication dictionary is another huge dictionary that has to be looked at. Sometimes there's a whole committee that just focuses on this, because you need to look at different things like on the trade name. How are you going to format it? Are you going to add the dose? If you have special identifying information, is it going to be at the beginning, the middle, or the end of the name to make it easier for the users to find it or to group them together when they're searching? There's just a whole slew of items specific to drugs that need to be looked at. Just like on the trade part, you need to evaluate the generic equivalent and make sure that you've standardized on all of that information, and play around with how it shows up when you're searching in lookups, when the nurses and the doctors are actually placing the order. Any changes you make, you need to play around with your formulary service vendors so that when you do your data upload every month, make sure it doesn't make changes to what you've done or negatively affect the load, or make sure the load doesn't negatively affect all of the work that you've just completed. When you roll out Cpoe, are you going to be interfacing with any outside equipment or other software? This can cause a huge problem with doctors with they're trying to not only learn the new process for Cpoe, but now you've thrown in some new, say, pharmacy dispensing equipment or items that they now have to use and add into their process. If you don't have those interfaces set up and tested, or if you're using a company that isn't well known and doesn't have a history with Meditech, you need to make sure that's set up early and that it works and that you've properly trained your people, especially in the emergency department, because they get very frustrated because they don't have a lot of time and they're dealing with very severe cases of patients, and they have to move quickly. And if they need a drug and they need it now, and you've interfaced with the system and now they're not able to get that medication, it can severely halt your Cpoe project. Evidence-based order sets are now becoming a requirement within the industry, and two of the top ones that work well with Meditech are Provation and Zincs. You need to do some research to figure out which one is best for your facility. You need to identify your requirements of things that they have to be able to do, such as the ability to customize the order set to meet your requirements. They have to have automated updates. They have to easily integrate with Meditech. Look at how the training and deployment will affect your staff and any updates that have to take place for that software. What other requirements for your staff to keep those up to date? What terminologies are they recognizing? ICD-9, ICD-10, SNOMED, CPT, LOINC codes, and what are their alternatives for your downtime process? Downtime is huge, and so you need to be able to make sure that even in the event of a downtime, that this company is going to be willing to work with you. As of 2010, some of the positive and negatives that we knew from each company is Provation has a lot lower cost. But it's server-based, you own the content, it's yours. Zincs is web-based, and you pay a subscription fee, and the content belongs to them. If you use Up-to-Date and you don't want to change that product, make sure that they integrate with Up-to-Date, because at one time Zincs was not interfacing and playing well with Up-to-Date. Same with Dynamed. They were not interfacing or integrating with Zincs. So just make sure every piece of software that your doctors and nurses are going to use works well with this system. Reflex order sets have been around for a few years, but not all facilities are currently using them. They allow users to generate one or multiple orders based on placing a single order, medication, or by a response to a query. So when you're setting up a reflex order set, you have three types. You have a suggested order. So when you're placing an order, they're suggesting that you also order something else. There can be a prerequisite. So if you're placing an order for something and you have to have another test done before it can be performed, then that would pop up. And you also have the ability to link orders together for medications. So make sure that if you are not currently using reflex order sets, that you check into that. If you're converting from another system into Meditech when you go with Cpoe, you need to talk with other hospitals that have gone from the software that you're using into Meditech. You also need to have conversations with Meditech to make sure they have experience with this system, because if not, it could take extra manpower or extra testing to make sure that the data comes across correctly. When it comes to training in today's environment, there's so many options that you have, and each facility does it a little bit different. We've seen hospitals that will do computer or web-based training, and it's all online at the doctor or the nurse's pace. Whenever they have time, they can log in and take it, or stop anytime and come and continue whenever it's convenient for them. Other facilities want to bring you in for days at a time and have you sit there in front of the computer getting hands-on experience. While even other facilities do a combination of the two. Whatever you do, just make sure that you have a timeline laid out and that you also build in extra time, because there's always people that are going to have to retake a class, or they're going to miss a class and need to make up for it. So we're going to look at some of the specific requirements for things that need to be addressed in the training. One thing we highly suggest is that you group the same types of clinicians together, so that when you're in training, you can focus on, here's how Cpoe is going to be rolled out in your department, and here's how it's going to affect your workflow. If you have a mixture of OBGYN and surgical unit staff and ICU staff, their work's a little bit different, and they'll have different questions, and it's easier if you just train all of the same types of clinicians at the same time. A few things when you're training your providers that you need to focus on is the exact process now when you're doing a direct admit or taking an ED patient to inpatient. How is that process going to work? If they want to place a single medication order, how do they do that? If it's a protocol order set, how do they do that? How do they add items to their favorite list? What are all the different order sources and what do they mean? How do I place an order for a consult or a diet? What if I'm transferring a patient or DCing one? What happens? How do I do that? Somebody placed an order on admission. How can I do that? Or I need to edit an order that was on admission because I don't like the way that it's set up, or I don't want that order. What do I do? And what's the difference between signing an order and signing an order set, and how do I do it? Medication reconciliation and the discharge process are a huge part of Cpoe. You need to make sure that you have those processes down in place and know exactly how medication reconciliation and the discharge process work and how it works between departments. And if you have LSS or any other ambulatory software and you're sending that patient home, how does that affect their side of the software? What are all these alerts that are popping up? What do I do with them? How do I handle them? I'm getting ready to pass my patient off to the nighttime clinician or provider. How do I do a handoff? Or they hand it off to me now. How do I check the chart? What do I do? Computer system's down. What do I do in a downtime process? I need that patient information. Where am I going to get it from? I now have this desktop with all of these orders and results and messages coming to it. What are they? What's the groupings? What do I do with them? And again, if you can make it specialized to their department and show them how it will affect them in their environment, it'll be much better training for them. Providers aren't the only ones affected by Cpoe. Nursing and other clinicians will also be affected. Not only do they have to deal with the frustration of the provider now having to enter this order in the computer, the nurse is going to have to know, well, did he enter the order in the computer? How do I know? When do I know that this order needs to be complete? Where's my patient going to get the order done? Now there's all these new order sets out there. What are they? What do I do with them? I'm transferring orders. I'm doing medication reconciliation. What are the new changes that come along again with Cpoe? Is it different if my patient's inpatient versus outpatient? You also need to have a process for discontinuing things that were ordered in another department and the patient's coming to your department. A lot of this stuff on the screen, there's a lot of information packed in here, so you can either download the presentation that we've attached to this, or you can contact us and we can send you more information so that you can read through this information. Downtime is especially important for this group of employees. They will not only have to deal with the frustration of not being able to do their orders and documentation, but the doctors are going to be yelling and screaming at them, what do we do? How, where's my information? Get this done. So they need to know exactly what happens in downtime. They also need to know the statuses of order sets and what each status means.